Hello, everyone. Thank you for joining us today for our Webinar Wednesday. Today, we're going to be focusing on MS DMTs, how to choose, and when to switch. This webinar series is brought to you by Can Do Multiple Sclerosis. My name is Paige Kennan. I'm a programs manager here at Can Do MS, and I'm going to be your moderator this evening. I want to take a brief moment to thank our generous sponsor for supporting this year's webinar series. Thank you very much. All right, tonight we are joined by nurse practitioner Kathy Costello. Hi, Kathy. As well as neurologist Matthew McAdams. Kathy, Matthew, thank you both for being here. Kathy, I'll kick over to you and you can get us started.
Great, thanks so much. So welcome everyone, and a big welcome to our new participants, and also welcome back to those who have participated with us in the past. So happy to have you with us, and how about that, starting off 2024. So tonight, as we heard, Dr. McAdams and I will be discussing MS DMTs, initiating therapy, but also understanding when a therapy switch may be needed. And we'll do our best to answer your questions during the program, but time's always tight. There's always so much to say and so little time. But we want you to know that you can email us at info@cando-ms.org or join that Your Questions Answered session that Paige mentioned, where we will be talking about MS treatment options. Dr. McAdams, thank you so much for sharing your expertise and your time with us this evening. I had the great pleasure of meeting and listening to Dr. McAdams in the fall of 2023 and knew immediately that I wanted to ask him to be a part of a Can Do program. And so I was really excited when, yay, he said yes, and here we are. So before we dive in, Dr. McAdams, if you'd like to just share a little bit about yourself and about your journey as an MS professional, and then we'll dig right into our slides.
Well, thank you. I want to say thank you, Kathy, for inviting me. It was a real pleasure to hear you talk as well during our shared symposium. I'm very pleased to be here and to talk and have this opportunity to share what I can with persons with MS. This for me, and I'll hopefully won't take too long with this. This is a personal journey in the sense that my godfather was diagnosed with multiple sclerosis when I was in high school. And he's a larger than life gentleman, we'll just say, 6'4", 300 pounds, used to throw a party for over 200 people at a time and do all the cooking. And then one day he couldn't walk across his own house without stumbling and falling. And it took him a while as a gentleman to get diagnosed with MS. And before that, I was going to be an actor, likely a starving actor, but yes, I chose at that moment to say, let's fight the good fight against multiple sclerosis. And it took me a while, but here I am. As you can see, I owe BU and the government a lot of money, but I'm very pleased with my education, and it certainly has equipped me well in order to help MS patients.
Thanks very much for sharing that, Dr. McAdams. So with that, let's dive in. As we know, there's over 20 MS DMTs, which is awesome. But it's also confusing and complex, and it's an enormous amount for any person to even try and attempt to digest. And yet that's what we're asking of people. The minute they're diagnosed, we're on our way talking about treatments. And so I'd like to start off, if you can, and there's some points on this slide, but if you could just give us a little bit of an overview of DMTs for MS in general, why we think they work, what the evidence has said to us, how they were tested, those kinds of things, just to level set us on what we have here. And then we're going to get into some specifics.
Certainly, I'll try to wax poetic about everything, and just bear with me if I misspeak tonight. I am recovering from a certain respiratory illness, we'll just say. So first of all these medications have been studied by the FDA and approved because they've been shown to have benefit, and those benefits outweigh any potential risk of the therapy. So in general, that's a good starting point. You want to have that approval beforehand. And in order to study this, they had to figure out what were the aspects of multiple sclerosis to follow. And really, it was the advent of MRI technology in the early 80s that allowed for the the clinical development of multiple sclerosis medications to occur. And so we found that basically, if you have less lesions form in your brain, you have less clinical disability. And so when we started using therapies that had an effect on decreasing the number of new lesions, that was something that we looked at. We looked at a decrease in the number of new lesions forming in the brain and spinal cord. And we also looked at something called clinical progression or worsening. And we would basically do a clinical exam before, after they started therapy, and forward, and making sure that there's no worsening over time. And so basically pairing these variables together, the FDA can say that these are safe therapies for decreasing the rate of activity or attacks, and either clinically or radiographically in patients. So this is how therapies got approved, is basically showing there's less lesions, people are having less disability. So these are all good things. And over time, we've gotten better at measuring those things as well. So just knowing that a medication is FDA approved does, should assuage the average patient to a great degree. Now, all of our therapies either modulate or deplete part of the immune system. And that depends on the therapy, which we can talk about more granularly, but not too granularly later. And like I said, they do limit new lesions or new spots from forming on the brain and spinal cord. And we know that when you stop that lesion formation, people will do better in the future. So that's one of those, a point I'd like to make early on is that starting therapy earlier is better in general. And there's not an end date to that per se, but earlier is better, because the more you stop lesions, the less disability you'll have in the future. It's a pretty easy line to follow. And like I said, they reduce those attacks and relapses. And if you, over time, if you do decrease this line of basically disability progression, basically you level it out, the patients aren't noticing that they're worsening over time, that's helpful too. So now all therapies that we have that are FDA approved are basically allowed for relapsing forms of multiple sclerosis, and they're relapsing and progressive forms of multiple sclerosis. Now, there is only one approved, FDA approved, for primary progressive MS.
Thanks for that. So obviously best to start early. There was a question that came in with registration about someone who had never started anything, and is it now too late? And I think you alluded to that, but just what would be the expectations if someone hadn't been on a therapy and now they want to start?
I coming into this practice where I'm currently at, I inherited a lot of patients who are not currently on therapy, and there are people who had been without therapy for decades, right? And so a lot of patients have had the same question, and my experience, at least anecdotally, is that there's no end date to starting therapy, and that patients can actually benefit and may even have some confirmed disability improvement with starting a therapy, even if it's later. Because if you have active inflammation in your brain, it basically makes it harder to do things. So if you tamp down that inflammation, patients, especially when you start a therapy at the beginning, can note a big difference.
Thanks for that. I appreciate it. Paige, let's move on to slide number 2 of ours anyway. So what I'd like to do here, Dr. McAdams, is we have 3 slides that are on the different administrations of disease-modifying therapy. So we have all the oral therapies, all the self-injected on the next slide, and then on the 3rd slide, all the infused therapies. And while we could spend the entire hour talking about one drug, okay, this is kind of getting an idea of how they're expected to work, maybe a little bit about side effects and risks. There's been a few questions already in the Q&A box about some side effects. And so maybe just touch on some of the major ones if you can, and maybe just a few minutes, and then we'll move on to self-injected and so forth.
Of course. So I'll try my best to give a 20,000-foot view of oral therapies. And first, I want to say that oral therapies definitely have a place in the care of MS patients. They were a mainstay, specifically the fumarates, for quite a number of patients over the years. Now, they are oral therapies, and that means that they're taken orally, and it depends on which one, how often you have to take it. So I'll break it down by that a little bit first. The teriflunomide is taken just once daily, and so are the S1Ps taken just once daily, whereas the fumarates have to be taken twice daily in order to maintain efficacy because they have what's called a short half-life. They're out of your body quickly. And then there's cladribine, which is in itself its own little group, if you will, and that is taken basically just 2 weeks over, and that's done just over 1 year. And then the next year you take it for 2 weeks, and then you do not take an additional therapy for another 2 years typically after that. And I say typically because everyone's different, and you may have to take a therapy even though you've taken the cladribine over those time period. So teriflunomide and cladribine do have different mechanisms of action, how they work, but in general, it has to do with decreasing specifically overactive immune cells called B and T lymphocytes. So there are those that normally replicate that help us fight off infections and the like, but these help select for those that are more active and are typically autoreactive or against the self. Okay? And in general, teriflunomide has issues with hair loss, which can be quite the limiting factor for a lot of people. It can give you GI intolerance, and it can cause liver elevation. You do need to monitor blood work quite frequently, monthly, when you first start this therapy. Cladribine does have a side effect profile, and it does have black box warnings based off the amount of times you can't use it beyond the 2 years, because after that's associated with malignancy development. And there is an increased risk of upper respiratory infections, of course. And that is typically seen with a lot of these therapies, but I do want to make a note later on about in terms of infections and multiple and disease-modifying therapies later. So Kathy, if you'll remind me. So the S1Ps, they work by restricting the lymphocytes into the lymph nodes so that they don't go in and attack the brain. That's really the major effect that they have. So they restrict them. You still have them. We're not killing them, but they're just not going to the brain and attacking it. And they do have some side effects, mostly the initial ones you had to monitor when you first started it because it could slightly slow the heart rate. And you do need to be seen by an ophthalmologist when you start these therapies, and a regular occurrence. The fumarates, like I said, have been a mainstay of therapy for a lot of patients in MS. They were one of them. The Tecfidera was the most prescribed at one time in the nation. The fumarates are very small molecules, and they work actually many different mechanisms. Some by depleting those lymphocytes that are against you, right? But mostly by activating what's called a niacin receptor. So the niacin receptor causes people to flush. So a side effect of taking a fumarate is that you can turn beet red, right? And so that is something that can be socially, disabling to a certain degree, but there are certain things you can do to mitigate that, like taking it with food and the like. Now, they do have other side effects, but I actually want to point out that the fumarates actually are shown to help metabolic syndrome and bone health, actually, which is interesting, as not a side effect, but as a sidecar benefit. Yeah.
Yeah. So do they help with bone density? Is that what you're
They
what you're
increase bone
alluding to?
density, and it's thought to be through activating certain aspects of bone remodeling. Yeah.
Oh, okay. What a
I,
nice
I,
side benefit.
I don't want to gloss over the fact that they do have GI side effects. I didn't mention that, and that can be mitigated by starting it slower, and basically increasing it slowly over time.
Thanks for that. And I know there's a few here that are particularly, we have to be particularly wary about them with people who want to start a family. And I know that that's the case. There's a lot of questions that pop up about older folks being, should I be on a disease modifying therapy? Are any of these red flags? Certainly speak to the pregnancy and breastfeeding issue, but more so that depression or older adult, are there red flags there that people need to be aware of?
In terms of these therapies and being elder, sorry, can you repeat the question?
Yeah, in terms of these therapies that are on the screen,
Yeah.
the risks in pregnancy, but also are there any particular red flags for the older adult? And is there any benefit that we're aware of in terms of progression?
So the S1, I mean, basically all of the oral version is, basically not recommended during pregnancy and so have to be stopped. We do, and when we jump ahead to injectables, we can talk about how that is allowed. In general, I have used all of the above therapies in people up into the age of 86. So there's not an upward limit on that. I do think that patients with, who are older can be more sensitive to medications and require more intensive safety monitoring with either lab work or the like. But I haven't seen greater intolerance in terms of like age related. I find that it's not ageist, the GI side effects for these things.
Right. All right, good, thanks. I hope that helped a few folks who had put some questions out there. Why don't we go ahead then and move on to this, I believe self-injected therapies are next. Now there's a few of these therapies that have been around a long time and then one that's relatively new. So please take it away and tell us what
Okay.
you know.
So let's start with the glatiramer acetate. So this is actually a series of peptides that mimics the outer coating of myelin. Myelin being that part of the neuron that actually covers the axon and helps it conduct quickly. And that's the part that is actually attacked in multiple sclerosis, and it denudes or makes that axon naked. And so when you mimic this, it's almost an effect like telling your body to be okay with it. It's a tolerance. So it's not immunosuppressant whatsoever. It just modulates it. So it's almost like saying, be okay with myelin. Basically, stop attacking it. It's okay. So and this is considered one of the safest therapies. And I've seen a few chats just pop up, and maybe why I had to have the question asked again is that a lot of people are saying they had adverse reactions to these. Now, in general, I do consider it as safe as water, but I call it angry water. Basically, it can give you lumps, bumps where you inject it, and those can cause, divots in the skin, and it can cause like red bumps, and it's not comfortable, right? And in addition, if you happen to accidentally inject it into a vein, you will feel very poorly for about 15 minutes. Yeah, and so I've had a lot of people, and I've seen people say I had an allergic reaction to it. But in general, that's when people inject into a vein or have leakier veins and have the systemic mainlining of glatiramer that causes this sort of reaction. It is considered a very safe therapy. There are certain providers who will put patients on it during pregnancy. So the interferons, and beta-serin being the first one that came to market as a disease-modifying therapy. And Kathy, we were talking last night about how there was even a lottery at that time because there wasn't enough medication to give out at that time. So the interferons, they have about 26 different publicized mechanisms. So I won't go into all of those. But in general, if you think about interferons, you think about basically antiviral. So if you get sick with a cold or the like, you will feel crummy, right? And so that's the side effect profile of interferons typically, is that you can feel crummy from that interferon response, but it does help regulate the immune system and decrease inflammation. You do need to monitor liver and patients who are predisposed to depression. It is something that they can worsen depression. So this is something to be aware of. Now, Kesimpta is the new kid on the block, but despite that, its mechanism of action has been used even off-label for many a decade in the treatment of multiple sclerosis, because earlier version, Rituxan, and then now FDA approved, Ocrevus and now Kesimpta, even though it's the new kid on the block, it works the same way as these other therapies that we've had around for a while. So Kesimpta is one of these, and I'm just highlighting that it's considered one of the highly effective therapies. So it has a stronger mechanism of action by depleting these B cells. And B cells, it makes people worried that you're depleting these B cells. And, it's something that like a lot of patients are concerned about. In general, there's going to be an increased risk for infections. But clinically in practice, I have found it's more so if you get sick once or twice a year, it's more like you're getting sick 3 times a year. And if it takes you 5 days to get over something, it's going to take you 7 days. And I'm not seeing a great increase in overall infections on these kinds of therapies. All right. You do need to be monitored with blood work. And in general, patients are quite satisfied because if you're looking at the different injectables, just to note how often you have to inject it. So glatiramer acetate has a 3 times a week you can inject, right? The interferons, depending on which one you use, it can be weekly or several times a week, and or even over several weeks. But Kesimpta has the 4 times a week, and I'm not trying to say use Kesimpta to anyone, but I'm just saying that there is a lot of mental space that patients can give back by less frequent administration of medications.
Thanks for that. With the Kesimpta, I know that with Ocrevus, there's an indication for primary progressive MS, and there's some parameters around that from what we know from the clinical trials. But would we anticipate then the same indication here or the same efficacy?
So, I mean, it has the same mechanism of action, has stylistic differences in the terms of like, hey, it kills the B cell this way, but the B cells are dying. And interestingly enough, it is actually different from Ocrevus in that it's less immunosuppressive. So because it's subcutaneous, it bypasses what we call, the splenic lymphocytes. So patients can get vaccinated easier on these types of therapies. That's something that it's a little bit harder on the infused B cell depleters that we'll talk about. Yeah. So in general, it's it's well tolerated, and especially after someone's been on it, because when you first start these therapy, you're breaking up these cells, and when you break up cells, that can dehydrate you, and basically you have to do some things to sort of buffer the system before you do this. And in general, most medicines, they have tweaks that your physician can help you work through to make sure that you have less side effects.
Excellent. Thank you for that. Let's move on then to the infused therapies. And then there's a question I have to keep in mind that I want to ask you when you're all finished here. I've got a kind of an important question. So here we have, these are, other than one, which is actually a very old drug that, thank heavens, is rarely used, and that's mitoxantrone, just because of its side effect profile. But the others are all relatively new on the treatment landscape. And one, actually, I put it on here, but under natalizumab, Tyruko is FDA approved, but it hasn't been marketed as yet. So again, if you can include that in your description, that would be terrific.
Of course. So natalizumab works by basically preventing those lymphocytes that are working against a person with MS from entering the brain itself. And this is a double-edged sword. It's very effective at decreasing new lesion formation. But as many patients who have had this disease for several decades will know, is that at one point it was taken off the market briefly when it was discovered patients were developing PML. And I want to be very clear, this is not to scare anyone from using this, but it is important that if you do have the John Cunningham virus, that you're monitored for this. And that is actually part of the safety monitoring that's required by the FDA to use this medication. So in general, my personal practice is to have only JC virus negative patients who don't have this virus in their body on this therapy. And if they seroconvert in the future, I typically talk about switching. But it is quite efficacious. So it is part of our armamentarium as an MS physician, and there are patients who it benefits, certainly. So the B cell depleters, it does work, as I said, like Kesimpta does, by depleting the B cells. And those B cells are cells that are in our body that help keep a memory of what you're supposed to attack to a certain degree. Now, it's thought to be that depleting the memory B cells helps with preventing MS activity. And these are highly effective therapies as well. And sorry, I know you asked me to go about Teruko. The biosimilars, again, I do think that of these as equivalent. So like that's why I sort of didn't go into it too much, right?
Sure.
So Ocrevus and Ubliximab, these are two B cell depleters that are infused. Now, Ocrevus is the first one that had FDA approval, and so it's first to market. And a lot of MS providers have a lot of experience with using it, and it is considered highly effective. One of the things you do have to look out for is it does lower some of the proteins in your blood that help protect you against infection. And so if those get too low, people can start getting more UTIs. So it's something that I monitor with what's called IgG, and it's something I get before every infusion. So Ubliximab was more recently approved. Its claim to fame is it's a faster infusion and has a little bit change in how it binds to those B cells, and thought to be sort of more, basically cause this lysis a little bit faster, maybe induce the benefit quicker than the previous integration or previous therapy Ocrevus. So mitoxantrone, as you know, I won't go into too great detail, but we'll just say it's a big gun. I haven't used it. I have plenty of patients who over the years have been exposed to it, and it was quite effective, but cardiac toxicity really limits its clinical use. Now, alemtuzumab, I also consider a big gun, but if you're across the pond in the UK, a lot of patients receive this. Now, you can think about it as like we're taking care of just some of these superficial cells, whereas Lemtrada is really taking out sort of like whole lines of cells. I call it a reboot. And the thing is, when you reboot someone's system with multiple sclerosis, an autoimmune disease, they can develop other autoimmune diseases. So that's one of the risk factors of alemtuzumab. So it's something that I hold in reserve if I have someone who's breaking through in other therapies, because it is quite efficacious, but it does come with a lot of laboratory monitoring, basically for a long, long time.
Thanks for all that. It's a lot of information. So with the natalizumab, we mentioned PML and testing for JC virus antibodies. I know that that's not required for other therapies, but from time to time, we do see PML pop up with the other therapies. And I'm going to assume, you can correct me if I'm wrong, that that's due to the impact that these drugs have on the immune system. And the central nervous system being mostly a privileged compartment, if you will, certain things don't generally get in there. But if we change things around immunologically, then we can allow things we don't like to actually get into the central nervous system. Having said all of that, what other of these drugs that we've mentioned thus far would you say, or do you have any concerns with a risk? We mentioned the B cell depleters with infections, but that's not necessarily PML. So where else might you see that?
So I will say, if we could actually go back, it's with the oral options.
One more.
Yeah. One more back. There we go.
There we go.
That we've seen that with the S1Ps and the fumarates, and those have to be with the fact that if you restrict those lymphocytes from going to the brain, you're also restricting those ones that monitor the brain for basically these viruses. So there are things that I do, and it's not required, but and it's an individualistic practice, but I in general am monitoring the John Cunningham virus titer in all of my patients on immunosuppressive therapies. So that's basically everything except for glatiramer. So I want to know this person's number. And while there isn't strong data that say this is a cutoff for that, in general, I don't like to see it go up. I like to see it go down. And, there are certain basically health practices that can help improve a healthy T cell response, in my opinion, which means like basically sleeping well, eating well, exercising can actually help improve those T cells that help monitor your brain for this, scary infection and actually bring down that number. So it is a risk factor. And again, this is something that when you're talking to your doctor, you will need to talk to them about. So the S1Ps, the fumarates have this as a class risk. And now Tysabri has the highest number of patients who have had this happen, but the S1Ps and the fumarates are behind, right? So if we could
Right.
go to the injectables, there's been no cases of PML on any of these therapies. Now there are carryover cases from people who switch, but there's nobody who's developed PML from these therapies, including Kesimpta, even though it's a B cell depleter. Okay, and then can you go to the next slide, please? And then Tysabri, like we said, is Ocrevus has had 2 cases. Now, of those 2 cases, the first case that had PML did have low lymphocytes before they started, which was an independent risk factor for PML. So in general, our center, we have a cutoff that says basically if your lymphocytes are this low or lower, you don't get your Ocrevus. And we'll talk about different plans. You'll come and see us for a quick meeting, right? So we have safety monitoring labs, even though there's only been 2 cases and the number of people treated is quite large. It's, I believe, the most used infused therapy for multiple sclerosis, right? And in general, there's a lot of people been treating, and there's only been 2 cases. The other case was in Spain, and we don't have a lot of the details from that because it's an international case. But the other one, they had a pre-exposed or pre-existing factor that put them at risk for this, and that can be mitigated by monitoring with lab work.
Yeah. Thanks for that. Paige, we can go to the next slide. And this was a really fast overview. There's lots of information out there. There's information about disease modifying therapies on the Can Do MS website, certainly the National MS Society, MSAA, MS Foundation. You can pretty much find more details about the drugs. But we did want to give you at least some of that information in seeing them kind of all at once. Why? Because the question becomes for everybody with this complex landscape, which one should I be on? Right? And as it turns out, when people are part of the decision in for this and for other things, that they actually do better. People adhere better, they manage side effects better, and actually have better outcomes, which is remarkable to me. So being part of the conversation and being part of the decision is very important, but it's also challenging. So let's talk about, Dr. McAdams, how you approach this, your role versus the persons with MS and their role.
Well, thank you. I think, like you said, it's really a shared decision, but I do try to pare down the field. I've had inherited certain patients will just say that got handed basically all the pamphlets for all the existing therapies. And I don't necessarily think that that's the right. I am here to curate a list of therapies that I think would be right for the patient. And like there are other ones, and if you don't like what I've offered you, we can certainly talk about them, but I'll tell you why I think that the ones that I've proposed are the right ones to consider, right? And so I do try to explain that, and I take into account the clinical status. So where there's a beginning, middle, and ending to everyone's not story, but like in terms of the disease state. And so in general, I'm trying to say how inflammatory is someone, and typically earlier on in the disease state, there's more inflammation. So I try to take that into account. What do we know? Do we have several MRIs to actually show that they're quite active? Or do they have a lesion that I know portends basically a worse clinical outcome if we don't treat aggressively? Like, and are there actually demographic aspects? Like, are they male? Are they Black? Or do they have spinal cord damage? These are factors that can be considered high risk for development of future disability and indicate a need for highly aggressive therapies, right? And by highly aggressive, I don't necessarily mean more dangerous or scarier. Yeah.
Well,
So,
that brings me to, before you go on, the term that a lot of people have heard is high efficacy disease modifying therapy versus moderate efficacy. So I think that's what you're really talking about then, is the aggressive therapies, but those that, based on their clinical trials, have a more robust impact on relapses and inflammation and maybe even some delay in progression. Am I right?
absolutely. You took the words right out of my mouth.
So now what about the person with MS? I mean, they're not immunologists here, but they have
No,
an important role.
yes. And I would say ultimately tell the provider what you're thinking, right? Like, oh my gosh, I have a friend with MS, they take this and they said it was terrible. And realize that you have an individualistic disease state, right? And so realize that, like, while your friend might have had this thing happen to you, it's not going to say that that's going to happen to you. We all have different genes, and basically our exposure to medicines and how we respond to them is going to be different. I think we're getting closer to personalized medicine, but what I tell patients is I don't have your genome in front of me, right? I am going from experience and how people respond to this, right? But ultimately, you tell me if this is intolerable and we go forward. But knowing what you want from a therapy, right? And if you're saying that what you are offering me isn't going to work for me, like that's a discussion. But also, how do you want to take therapy? I have plenty of needle phobic patients who are just saying, like, absolutely not. And there's certain ones where I've actually talked them into taking a different therapy, and they're like, well, you were right. It wasn't as bad as I thought, right? So it's a discussion, and I'm not here to force anyone to make a decision. But if you don't tell me that you're afraid of needles, I can't make sure that, like, we either have that discussion or the like. So fears are important things. And listen, I mean, I get asked about PML a lot, and I don't, and it's okay to talk about, but realize that it is a astronomically low risk, and we want to decrease your individual risk for it, right? But ultimately, we also don't want that fear to take over and keep you from starting therapy, because in general, this is not something that we see. So, and risk benefit, in general, the risk is higher. But like, ultimately, some of these things might happen, right? You may lose hair, you may have difficulty, and you may have liver elevation with certain. So if that happens, that's when you meet with your provider again and you pivot. And that's something that we can talk about as well.
Yeah, so when someone can maybe write some of these things down ahead of time, just so that they have an idea of the things they want to talk about, because those goals, those fears, that risk tolerance, your lifestyle, your desire to have a family, for example, do you want to start your family this month, or is it 5 years away? Right. So, I mean, but those questions make a big difference in that collective decision. And so I think sometimes, and I've been in this situation too, there's a little bit of intimidation when you're in front of a healthcare provider, because they hold a lot of knowledge. That's true, but they don't know you. And I think that's the key to confidence, is that the only person that knows you is you. And so my thought is to write down these things that are important to you so that they are part of the conversation.
And
So
just to
with
clarify,
that,
I saw people ask about PML. PML is the John Cunningham virus. A quick aside, the John Cunningham virus is a virus that is ubiquitous, means that a lot of people, around 90% of humanity, have this virus latent or quiet and not doing anything in their body. But certain issues like AIDS, where the lymphocytes are astronomically low, and basically this virus can escape the immune system and cause trouble in the brain. And that has happened very rarely, but has occurred in some of these therapies. And so that's actually an infection by this virus. And it is quite devastating, but it is not something that we see frequently. So there's a lot of questions I see just popping up on the bottom here, and I wanted to make sure.
yeah, no, sure.
Yeah.
Sure. Thank you. Let's go on to the next slide. And here are just some of those questions. And you will have access to these slides, and there's more questions that may be on your mind, but the whole idea is ask a lot. Ask a lot of questions. And, when you feel comfortable that your questions have been answered, then by all means, it's time to make a decision. So this is just a start, but there might be other things on your mind that you want to know. There's been questions in the box about kidney function. If I have kidney stones, can I start on a disease modifying therapy? When there's very specific questions like that you're worried about, write them down, so that when you walk away, you have that answer. All right. So getting started, I always found, was the easy part, right? Someone has a diagnosis, and I mean, we're very excited to start someone on treatment. We know that early intervention has the best chance of great outcomes. However, things don't always go exactly as planned. And for lots of reasons, someone may need to consider a switch in their therapy. Or even they may be asked to consider stopping their therapy. So let's go to the next slide. All right. Talk to us a little bit about, first, before we get to actually switching, let's talk about how you monitor people so that you and that person have a good idea if this therapy is doing the things that you think it should.
Well, thanks for asking, because I think this is very important. It's not one thing, it's many, right? And it's the gestalt, right? And so the first thing I start with is what the patient is telling me, because ultimately how someone is doing and what they're telling me is the most important piece of data. Because I take that into account, because I'm not seeing them. I'm seeing them in an air-conditioned office, right? I'm not seeing them walk around in the heat. And so I trust what someone is telling me, is what I'm saying. And I think, again, I think this is the most important. So I'm the same, I'm better, I'm worse. I sort of start out my conversation with patients that way, because I sort of want to get the 20,000-foot view, and then, come down. Oh, I'm worse. Oh, how are you worse? Or, oh, my walking's starting getting to slow, or my right leg is starting to catch, and I'm starting to trip and fall from that. Or I'm having more urinary symptoms, or I'm having more difficulty with cognition, or even my fatigue is worse. So I try to keep an open mind and listen to someone as much as possible, because what you're telling me is the facts, right? Then I augment what someone is telling me with basically the clinical data of their examination. So I am looking at them, I'm saying, hey, your vision actually looks, stable. You can see the color red well. You can basically, your eye movements, you're telling me, that you're weak in your leg, and I can see that. I can also see that when you move it consistently, it doesn't seem to move as consistently as you want it to. Right. So I take what they're telling me, and I also make sure that I hit those points on their examination as much as feasible. And then I take the paraclinical data. And right now, for most patients, that includes multiple MRIs, and that depends on the time of when they started a therapy. So there's what we call a rebaseline MRI, where basically you get the brain, cervical, and thoracic after you start or switch to a therapy. And then I also, I'm basically, depending on the patient, I'm getting typically a brain annually or every other year, depending on the person. And then their spinal cord every other year. And when I look at that data, I'm not just looking to see if there's new lesions. I'm looking to see if any of the lesions have grown or even shrunk in rare cases, but happy cases, right? So I'm looking at the MRIs myself to compare to previously, and then I'm integrating this information with the patient in the office and saying, I'm hearing what you're telling me. I'm hearing you say that this leg, and I actually see that there's been some enlargement in, say, your thoracic cord lesion. We should talk about maybe switching your medication in order to help address that.
Excellent. So basically what you're doing is, in a way, answering these questions as you're going through that kind of, where is somebody, they functionally, what's going on with their exam, what's going on the MRI. And so these are the kinds of things. So again, these questions are questions you can ask yourself too, in preparation for your next visit. And one question that someone mentioned in the question box was about, what if my lesions look the same, but I don't feel the same? Like my neurologists get really excited. They say, hey, look, you have no changes in your MRI, but I feel like I've changed a lot. What is there a physiological or pathological basis for that?
Yeah, and so I think it's important to realize that there's limitations. MRIs are made by people, not by greater deities, we'll just say. So ultimately, it's not telling me what's happening at a cellular or histological level. So it's still, I'm interpreting something by looking at a funhouse mirror. It's not telling me fully all that data. We're not that good yet. Hopefully we will be, right? But that's something that happens over time as we make further discoveries and improve the quality of MRIs. So it's not the whole picture. You can have a stable MRI, but still have disease progression and still be worse on your clinical exam or feel worse. And that could be smoldering inflammation. And again, thank you for answering this. This is something that our field is beginning to understand better. And there's many different mechanisms for that to occur. It could be neurodegenerative, where you've actually lost some neurons, and we just can't pick it up on the MRI yet in those existing lesions that you have from your MS. Or it could be the fact that this, like I said, smoldering inflammation. And that can be what's called microglial inflammation. So microglia have the job of cleaning up the brain and spinal cord. They're your resident garbage men is what they call them. But then there are activated microglia, which I don't like the name per se, because it makes them sound like they're doing their job better. And hopefully you all forgive me for saying this. I consider them the drunk garbage men. They're running over fire hydrants. They're dropping trash everywhere. They're causing inflammation. But we can't see them with a regular MRI. We have to get basically a research PET scan to see that kind of inflammation. And we can see that in lesions that are considered inactive. So a patient can have an MRI that looks stable, but if we were to put them through this research study, like it may show up that there's inflammation around one of their existing lesions. Now, whether that becomes something that's clinically available in the near future, it would be helpful for specific cases, but I'm not so sure that that's going to be the case. And so, like I said, when someone tells me that something is worse, that is basically will be above this paraclinical data. So if someone tells me I'm worse, there's mechanisms for that. And you have to believe the patient.
Thanks for that. So again, this presentation will be available to you. These questions will be there. These are things that you can think about. You can bring them to your visit, or maybe if you're going over them yourself, you can shorten it down to just the ones that are relevant, that you've asked, and see if there's a need for you to switch your therapy. We're hearing now about people stopping therapy, and then after this, I think we'll take questions from the audience, but I would like to know your thoughts on this. There's been a few studies, one in particular that I think you'll mention, but if people have been stable for a period of time, sometimes their neurologist may say, we might want to take you off of your therapy. So what do you think about that? And what does the evidence tell us?
So I previously, we didn't have this data. And the first of the major 3 trials that has come out is the DISCO MS trial, discontinuing MS medications. And a broad overview of that study was that basically patients, when they were stopped greater than 55, who had been stable for a amount of time, basically, even despite that, had new lesions form in their brain. So there were patients having new lesions form in their brain, despite us stopping, or us thinking that it's okay to stop therapy, basically in patients who are greater than 55. And really interesting to me is actually those things that they didn't expect. That basically patients who were stopped on therapy had actually more serious adverse reactions than patients who continued therapy. So everyone says, oh, my MS med did this, my MS med did that. The thing is with MS is that we also know that it impairs normal T cell function that helps you fight off viruses. And also, if you swallow incorrectly, say into your lungs, right, that will cause you to have more pneumonia. Or if you retain urine, you'll have more UTIs. So also interestingly, there was an increase in infections when you stopped disease-modifying therapy. So when you stopped a medication that was supposedly, I mean, it is immunosuppressive, right, was actually, there was an increase in infections. So I think that's counterintuitive, and it's something that, like, it has, you have to wrap your mind around. But ultimately, when MS progresses, basically infections do increase.
Interesting. So that's good. There were quite a few questions about stopping. There's been a lot of questions about progression and what do I do about progression, which we've kind of talked about, I think. What you've talked about drugs use in people who are older. So I hope we've touched on a lot of the questions, but I know there's still more. I just want to summarize things really quickly, and then Paige, please pop up with those. So, okay, we want, in a perfect world, we want to start early, and hopefully people can persist with their disease-modifying therapy, limit the damage, reduce the attacks, delay progression. The decisions are best made by you and your MS provider, not either one alone. Sharing the information, sharing what's on your mind and what's important to you, and the provider will certainly share what he or she believes is important based on your particular MS case. And then consider all the factors when choosing a disease-modifying therapy. What we know about effectiveness, side effects, cost, risk, family planning, all the things that were on that previous slide that may impact the decision-making. So with that, Paige, what have you got?
Awesome. We have had lots of questions, which you have been answering along the way, so thank you for that. All right, so we had a couple questions I do just want to clarify on. So during one of our first slides, we talked about all DMTs being approved for relapsing remitting forms of MS, and then one being approved for the primary progressive. Can you just clarify one more time which one is approved for the primary progressive MS patients?
Yes, that's Ocrevus. That's the infused therapy.
Awesome. Ocrevus for primary progressive. And then people were talking about clarification on secondary progressive. Does that fall under one of these categories? Is there a DMT out there for secondary progressive?
So there does exist a criteria called secondary progressive, and this is, I'm a little controversial in this regard, and I'm just putting that out there, is that there's many different definitions of secondary progressive disease. And us as a field, the MS providers, haven't really agreed on just one yet. So in general, that makes it difficult to say that this is a separate disease entity. And what we are trying to do in more recent iterations and thinking about future, basically diagnostic criteria of MS, we're trying to get rid of these boxes because they sort of hold back clinical care, and trying to realize that MS happens on a spectrum. And basically people can be at different points of their life at, than what their chronological age is. So, saying that someone is secondary progressive, they can have active or inactive secondary progressive disease, but how do we, actually say that they're inactive? Is it because they have no lesions, right? Or they have no progression? It's complicated, is what I'm saying. And so these criteria, I try to tell patients to not get too bogged down in. I tell them you have multiple sclerosis, you have components of both of these disease aspects, right? That you have both an inflammatory and a progressive standpoint. And I know I'm not here to plug about like other things you can do, but just again, a plug about exercise and the well-being it can provide you. It is one of those tools in our arsenal against progressive aspects of the disease by releasing neurotrophic factors in the brain. So that's the one thing I really wanted to bring up is, even though I'm not here for that, is that exercise is one of those ways that can actually help improve outcomes in multiple sclerosis. So
awesome. Thank
Well,
you.
we can certainly appreciate your mentioning that along with disease modifying therapies. So thanks, Dr. McAdams.
Absolutely. And then just to clarify along those same lines, we've had quite a few people saying that, you know, their doctors really want them to stop a DMT at a certain age, which is what you're talking about. It depends on each person. If I'm a patient who thinks that I should still be on a DMT and feel strongly about that, but my provider feels the opposite way, how can I have that conversation? Have you had those conversations with your patients, and what should the next steps for those patients be?
I mean, ultimately, it is a shared decision, right? Because you can't have a medication without a doctor prescribing it, right? But in general, you know, if a patient wants to stop a medicine, I will listen to them. I will, you know, tell them the level of evidence before starting or stopping a therapy. But also I make sure that there is a plan in place to monitor someone and closer necessarily than while they were stable on a disease modifying therapy. So closer follow-up visits than, you know, would be previously done. So if I was seeing someone every 6 months, I might see them every 3 months for a while. I would do MRIs a little bit more frequently and sort of a graduated response saying like, hey, you've sort of graduated this. But I'm also saying like, hey, these are things to look out for. If you notice that your gait is worsening, if you notice that like these things. But in general, I am of, and this is a practice. And what I mean by that is that everyone has their individualistic practice. So for me, I believe that disease modifying therapy decreases disease activity and prevents future progression, and ultimately can keep people doing what they want to do for longer. And it could be that they were limited by side effects and they were burned previously. And that's a conversation like where basically you don't want someone to not take something because something bad happened to them in the past. But again, this is a shared decision. I'm not pushing people onto medicines. If someone says, I don't want to be on a medicine, I'll be like, just let me follow you then. And also continue to talk about it, right? Like as long as we're not shutting down that conversation, that's really what I want to have.
Awesome. And from what I'm hearing from you and from other people in the chat, you are your best advocate. So speak up and keep coming to Can Do and learning more. Unfortunately, we are running out of time here, so I will finish up with a few slides. Thank you, Matthew and Kathy. I've learned a lot tonight. If you want to continue to learn with us and join more programs, please connect with us on our social media pages. You can follow us on social, which will provide you with the latest programs, resources, and MS news. You can also go onto our website and you can register for our monthly e-news, and you can get all of the monthly notifications coming your way in your inbox. So once again, we want to give a huge thank you to this year's webinar sponsor. Thank you again, Kathy and Matthew, for joining us. Thank you all for joining us and watching tonight. We hope that this information has been super helpful, and we will see you again next time.